Muy buenos días a todos.
Good morning, everybody.
Buenos días y bienvenidos.
Good morning, welcome. I'm Dr. Gamaliel Gutierrez, Technical Officer in Arboviral Disease Surveillance at PAHO. On behalf of the Regional Arboviral Disease Program of PAHO, we want to extend the most cordial welcome to this important webinar about the clinical diagnosis and management of chikungunya. Before starting, I wanted to indicate that we will have a simultaneous interpretation into 3 languages, English, Spanish, and Portuguese. So far, we have about 200 participants connected. We will wait for a few more to connect. But before starting the activity, I would also like to say that we have opened the chat function in case you have any greetings or to report any problems with the translation. And also we have enabled the Q&A function that is in the lower part of the screen. We will use this function for those questions that you need to ask our presenter today. To start this activity, I will give the floor to Dr. Luis San Martin, who is the Regional Dengue Advisor of PAHO. Dr. San Martin, the floor is yours. Thank you very much, Gamaliel. Good morning, good afternoon to some of you and the entire region, all participants. I want to thank you on behalf of the Pan American Health Organization and the Regional Arboviral Disease Program, this group of professionals linked to the provision of medical services to patients in primary and secondary attentions and institutes that you devote some time to share with us and to hear the presentation and interact in this important topic of arboviral diseases. Today, we will talk about clinical diagnosis and management of chikungunya. Our presenter will be Dr. Kleber Luz, one of our experts and specialists in this topic. In the PAHO International Arbovirus Technical Group, our region, our continent, has a long history of fighting against arboviral diseases, dating back to the 17th century. In the mid-17th century, Barbados reported one of the first outbreaks of yellow fever recorded in the continent. In the following years, this disease hit both all the region, the islands in the Caribbean and the rest of the continent, and was progressively extended. And its transmission way was unknown. About 1820, 1881, Carlos J. Figley discovered the transmitter vector of yellow fever, Aedes aegypti. So it was a Latin American doctor who discovered the transmission agents. Then this doctor was involved in the detection of new arboviral diseases. Toward the end of the 18th century, in 1779, the bone destructive fever was described in Philadelphia and in North America. It was named as bone-breaking fever because it had alarming symptoms of arthrosis and arthritis. This completes the epidemiological picture of the arboviral diseases in our continent. But around 2014, 2015, 2 new arboviral diseases were introduced. The first of one, chikungunya, and the second one, Zika. and an emergency was declared. WHO named Zika a public health event of international importance because its effect in fetuses and newborns. Chikungunya, which was introduced for the first time in the continent with the first record in 2014. That year, the surveillance epidemiological systems reported more than 1 million cases in the continent, entered through the Caribbean islands, and then it extended to the mainland. And in the following years, was determined to be an endemic and epidemic potential disease. In 2016, 2017, chikungunya was reported through surveillance systems, more than 500,000 cases in the continent. And since 2017, there have been reports of no more than 300,000 yearly cases. In 2022, last year, this was the fourth largest number of cases here of chikungunya in the continent, getting close to 300,000 cases. And in the year so far, up to May, the region has reported more than 200,000 cases, with a variant that for the first time in the report we have mortality figures far greater than in previous years. During all this period of chikungunya introduction, approximately 500 cases were reported as deaths, but more than 40% is placed in the first months of this year. An important outbreak in Paraguay last year has extended to the first semester of this year, and Brazil, Bolivia, even Argentina have reported an important transmission of the disease this year so far. So after 10 years after the introduction of chikungunya, different factors having to do with the immunity levels and the time and the accumulation of new susceptible cases and climate change and more increasingly longer warm and hot seasons have had an impact of the disease in the continent. So today our special guest, Dr. Kleber, through a magistral conference will address the physiopathology, diagnosis, management and treatment of chikungunya cases with the objective of being able to prevent the serious and fatal cases. That's for this disease. This is our greatest priority. Thank you very much, and I hand the floor to Dr. Kleber. Thank you very much, Dr. San Martin, for your words. For the colleagues who have just connected, please remember that this webinar has simultaneous interpretation into English, Spanish, and Portuguese, so you can select the language you prefer. Please use the small globe, that's the icon that says interpretation. We have opened the chat function to alert us on any problems with the translation and publish comments or greetings, and then we have a Q&A icon for questions and answers. Now I'm pleased to introduce Dr. Kleber Luz. He is Brazilian, an infectologist, pediatrician, more than 20 years of experience of clinical management of infectious diseases, including chikungunya and Zika. He's a fourth degree associated professor of the Federal University of Rio Grande do Norte in Brazil, and he's a member of the technical group of Arbovirus advisory of the WHO and the international experts group of Arbovirus advisors at PAHO, supporting PAHO in different training activities and clinics and assessment process in the national programs of prevention and control of arboviral diseases. It's a pleasure, dear friend, Dr. Kleber Luz, to have you here with us, and the floor is yours. Thank you, Gamaliel. Good morning to everybody. And since we have simultaneous interpretation, I will make my presentation in Portuguese.
¿Puede compartir su pantalla, doctor, por favor? Todavía no estamos viendo su pantalla.
We are not seeing your screen yet. Could you share your screen, please, Dr. Luz?
Okay.
Si la puede poner en modo de presentación.
Could you put it in presentation mode? That's okay. Thank you very much.
We would like to start by recognizing Dr. Fabrice Simon, who was a military doctor from France who had a lot of work done in the area with chikungunya, and a lot that we are aware of and know now has to do with his work. And unfortunately, he died last year, and we would always like to remind him because he was able to train so many people here in Latin America and the Caribbean. This is our agenda. We're going to cover introduction, history, epidemiology, transmission. We will cover the pathogenesis of the disease because it's essential that people understand what is taking place when someone is infected by the chikungunya viruses, the clinical manifestation, differential diagnosis, laboratory diagnosis, treatment that is required for the patients who are suffering from chikungunya virus. In general, we will say that the chikungunya virus is transmitted by a mosquito, and dengue, yellow fever, and Zika are flaviviruses. And oftentimes these diseases are seen as arboviruses, but people need to understand that chikungunya is very close to dengue, sometimes yet, but we are able to come up with a different diagnosis. It's an acute febrile illness like dengue and yellow fever, but the characteristics is how it compromises and generates with arthritis, with polyoarthralgia, and compromising more than 5 joints. And unlike Zika and yellow fever and dengue, chikungunya can become a chronic disease. I'll give you his history. It's recent. Some people believe that chikungunya was the breakbone fever, but the virus was isolated in 1952, and the meaning of the word chikungunya comes from an African word that means the one who bends up and who is contorted. And until the 1990s, there were outbreaks only in Asia and Africa. But in 2023, we observe that the virus is occurring in more than 60 countries, and globalization of travel and trade, and especially climate change, have led the Aedes dispersion in the world, both types of Aedes mosquito. And with this, we observe outbreaks of chikungunya in many different regions. It's clear to us that chikungunya has 2 cycles, the salvetic and urban cycles, but the urban cycles are more relevant now than the wild one. We would like to cover some of the history of chikungunya. This was a report of an epidemic that was taking place in 1952 in Africa. And what does it say? We don't quite know if it was chikungunya, but people have fever, and diagnosis of this viral disease required an exposure to the infection. There was an outbreak in Africa where you could see patients suffering from the disease. And like nowadays, we all have to use epidemiological data to come up with a diagnosis for chikungunya. The absence of malaria parasites was very important because we can say this is not dengue, we can treat this as chikungunya. Recovery without specific drug, which is the situation nowadays. We don't have an etiological treatment of the chikungunya virus. And in 1955, these patients had a typical joint pains and frequently intense pain, and they also had a rash. And towards the end of this report, some patients would have a chronic situation that will last up to 4 months. This other report in 1968, we call the disease chikungunya, and there is a review of 10 American soldiers who were in Thailand, and they review all the clinical symptoms. There was fever, chills, headache, and also there was a compromise of the patient's joints. So 80% have a similar joint compromise, and sometimes it was characterized by inflammation. So you can observe the fever disease. It's 100% fever, and this fever drops as the patients recover after about 7 to 10 days. However, they are still showing some clinical manifestations. We didn't know for sure. There were some skin manifestations. So this is the epidemiology right now, where we see the coverage of different cases in many different continents, in Asia, Africa, in the Americas also, North and South America, and also in the Caribbean. It's a very significant disease. The records of the PAHO point out that almost 300,000 cases were recorded last year, expressing the importance of this disease in our community. So what is important for us? Chikungunya starts with a sylvatic cycle and an urban cycle. Most cycles, in most cases, happen in cities, in the urban cycles. That means that many people can get sick, which overwhelms primary care, healthcare, and we all have to be ready for an intervention as soon as possible so that these patients don't show any other problems that are more serious. We see the Aedes mosquito in the urban areas with a large number of people who are affected by the disease. And we see that the Hexa is the one that is going through right now, and it's present in Paraguay and Brazil. And we can see here, and this is a very important publication, it talks about the trends for chikungunya, and we believe that Aedes aegypti in this chart here will cover a region, and it's being spread, but the Aedes albopictus is also spreading. So we expect that there will be cases of chikungunya that will reach Europe and the north of Asia and north of Africa, and will continue to be observed in Latin America and the Caribbean. And we think that over the next 25 to 30 years, we'll be talking about these chikungunya cases in our community unless there is a highly effective vaccine. So unlike dengue, chikungunya is also affecting non-human primates, and it keeps the virus active in forests. And chikungunya is an alpha virus that is the highest number of cases, so that this acute disease can generate acute cases, but also generating chronic cases with that are highly prevalent. So what do we see here? The Aedes albopictus, which was a zoophilic virus that was only found in forests, becomes now an urban mosquito, and with the Aedes aegyptis becomes a vector for the chikungunya in our communities. So we can see that in cities like in Brazil and Mexico, in Peru, in Bolivia, all of these cities have a high rate of infection by chikungunya and production of chikungunya. So this is very relevant for us. It's obvious that the mosquito will become infected once they bite someone who is carrying the virus, and afterwards they will bite someone who is vulnerable. So what does it mean for us who work with healthcare? When there's a case of chikungunya, there will be another case down the road, and there is 80% of people who have a fever and joint pains. When we observe that that patient is infected, we are sure that there will be other cases of chikungunya, and we expect that there will be an outbreak of cases in that given community. So why is this happening? The chikungunya virus goes through a mutation, and this mutation A226V allows this virus to be more adapted to the Aedes albopictus, and this adaptation makes it present in the mosquito midgust and increases the dissemination. So we say there's global warming, the population is not being compared with the control of the mosquito. There is a mutation within the mosquito so that there is an adaptation to the midgut, allowing for the transmissibility. In general, the disease, chikungunya, is a self-limiting disease, even though it may take 10, 15 days or 1 to 2 years. It's a self-limiting disease. This is a complex spectrum disease. What does it mean? It varies. There are different clinical manifestations, and they can be typical, which we call the typical cases, and it can lead to severe diseases that can lead to death. One of the points we have to bear in mind is the presence of comorbidities can change this spectrum that is displayed in people. So the management of this has to do with covering a person who has chikungunya or a person who has chikungunya and is elderly or has high blood pressure or diabetes, because the comorbidities, they change the course of the infectious disease. So we have here an elderly person with chikungunya. We can see the malar erythema, and it's a relatively easy situation. This lady, however, has to go into intensive care because of breathing problems. And so we have the same virus with different diseases and that have had problems because of comorbidities, and then we have a skin rash. So there is a genetic background that may change the clinical manifestations in the patient. So whenever I see a chikungunya patient, what I have to pay attention to is the comorbidities and the clinical situation of the patient. So as far as transmission mechanisms are concerned, there are different possibilities. The most important and relevant is the mosquito bite. Obviously, someone can be infected because there is a mother-to-child infection for a newborn of a mother who have been infected. If a newborn is affected by a vertical chikungunya virus, the expectation is that this child will present a more severe case of the disease, more so than any older child or young person. So when the chikungunya hits people in the more extreme age groups, we will see a more severe situation with the disease. It's not being detected in breast milk, but we can see that this happens in cornea transplants, but this is not very relevant for epidemiological situation. It's very important to understand the pathogenesis of chikungunya. The virus itself has escapes the immune response of the host. There are cell receptors that allow for that, and the virus is inoculated in the skin, and potentially it can be inoculated directly in the bloodstream. So once there is a skin inoculation, the cells of the skin will allow the spread to lymph nodes, or the viral particles will flow in the lymphatic fluid. Many cells are the target of infections: fibroblasts, keratinocytes, melanocytes. Many cells are infected, and they will always hit the lymph nodes and will activate, which is very important, an adaptive immune response. The immune response will be the first line of response and will always lead to the participation of the cytokines, which will be working with the adaptive immune response with inflammatory cytokines that will make sure that this person, once sick, will have to seek medical help. I see that there's a lot of inflammation that is presented in the patient, and this is also replicated in the spleen and in the liver, and this capacity to replicate leads to high viremia seen in these patients. And if we see a patient like that, this person will most likely present a very high fever, which is a clinical characteristic of chikungunya, about 39 degrees Celsius, which is a high fever, which helps us differentiate chikungunya, which is different from the Zika virus that leads to a low fever.
So this infection capacity to infect muscle cells and myoblasts creates pain, muscle pain, and could produce muscle necrosis. We have cases that could have this condition, and some patients can be in a lot of pain. The virus activates the cells in the immune system, the T cells, the B cells, the macrophage, and this creates an inflammatory environment. And where does this happen? In the synovial joints. We were talking about this capacity that the virus has to replicate in several organs, in the liver, in the spleen, and other places, but the virus is also capable of invading the joints, replicating in the synovial fluids, activating the immune system, the adaptive immune system, and this is what generates the joint pain that we see in this disease. That could also be combined with inflammation and arthritis. This virus will be cleared within a few days. It will be cleared from the peripheral blood and the bloodstream, but the activation of the immune system could continue, and you could still see virus protein RNA in the body. So we have a disease that is produced by the virus directly, but it is also indirectly generated by parts of the virus, that is, proteins and RNA of the virus that also persist in the joints and cause the disease. And this is different than dengue. Once the dengue virus disappears from the bloodstream, we don't see any disease activity anymore. Well, continue with pathogenesis. We see there is the infection of the osteoblast and chondrocytes, and this generates bone loss, and it affects the cartilage tissue as well. And so patients could have issues that are very similar to rheumatic arthritis. Well, the viremia will disappear. However, the debilitating joint pain will start 2 to 5 days after the fever. So we have this sequence here. So first, the mosquito bite, 2 to 5 days, the onset of symptoms, and the symptoms are characterized by viremia. So that's chills, fevers, and then 2 days later, the person will start the joint pain. And the characteristic here is that it's a distal joint affectation. So you could see the spinal area affected, but usually it's a distal joint issue that affects the limbs. And so we can also see that the infected osteoblast could also lead to bone fractures in some cases. So besides the viremia and the joint problems, 2/3 of the patients develop a rash, and it could be a macular or papular rash. It could also be maculopapular. And one of the characteristics is the desquamation, the peeling, which can happen with Kawasaki disease and staphylococcus diseases. So 2 to 3 weeks after the infection, this patient could go through this desquamation. And we have mentioned the facial rash. I showed you a picture of that. And this is what we can see that is very similar to lupus. Now, how about neurological manifestations? These were not necessarily reported in the 50s and 60s, but now we are seeing that these are very significant manifestations, not because they are very frequent, but because they are very severe. So there is a neuroinvasive character here. We have characterized this, we have determined this, and this could be because of the RNA presence or also because of the IgM in the cerebral spinal fluid. So this neuroinvasive disease is a new characteristics that we see in the chikungunya outbreak that we have been seeing in Asia, in Africa, and in the Americas. And we know that the chikungunya virus produces the viremia. It invades all the tissues. So any kind of damage to the tissue could occur. For example, uveitis is seen among the patients. So very quickly, we have the virus here. It binds to the cell. It's internalized. It starts synthesizing its viral components and produces many of them. Right here we have the mosquito, which can be albopictus or aegypti. It goes into the skin. This activates the immune system cells in the skin. These cells are infected and they help to spread the condition, and it also activates the immune system cells, which creates the significant inflammation. So here is the diagram, and this is very important so that we can understand this disease. So the individual is infected a week before the onset of symptoms, 2 to 7 days here. This activates the immune cells, and then I have viral replication, great number of this, and this allows us to detect the RNA virus in the bloodstream. This is usually how we do it. So this is a diagnosis tool that is very important for us, and we should be using it in our practice. And then the response here is the activation of the immune system, producing cytokines with the IFNA factor and others, and this creates the acute symptoms. And then this viral load disappears quickly, and there is the production of the immunoglobulins, the IgG and IgM subclasses. And months after the IgM is introduced, it could remain present in the bloodstream, and this could make it difficult to confirm the diagnosis. So the persistence of the IgM for 2 to 4 months, sometimes even a year, could make it harder to um, actually diagnose the acute case. And the WHO has changed the diagnosis criteria and is asking for a diagnosis based on the detection of the viral RNA in the bloodstream. Since there was the spread of the virus to all the organs and tissues, I could see the virus producing manifestations here, and this clinical manifestation is a consequence of the activation of the immune system. I'd like to remind you of this. So this could show up anywhere. So we have the nervous system, liver, spleen, and a very important symptom is in the joints. So even though the viremia has disappeared, the joints could still be painful and affected for a long time. So you have myalgia and edemas in the joints as well. So when I see a suspected case, I can expect a mild case or a severe case, but I can also expect the manifestation to show up in any organ or tissue. So when you assess a patient, you shouldn't just check the bloodstream, but you should also do a detailed examination looking for complications that might be showing up on this patient. So here, very clearly, we had mentioned something about this. We don't see an axial effect in general. In general, we see the limbs affected. So shoulders, elbows, wrists, also the hand joints. You can also see this in knees, ankles, feet, and also close to the hips. These are the joints that are mostly affected. And right here, you can see that you can see more than 5 joints that are affected. And this is different than other diseases that might affect one joint. Sometimes we have diseases that affect 2 to 4 joints, but then we have this situation where 5 or more joints can be affected by chikungunya. It's a great number of joints. And also, this joint symptom is symmetrical. What happens on the left side happens on the right. This is what we expect to happen. So it affects many joints and it is symmetrical and it is mirrored too. So what happens on one side happens on the other one. So if you have the left elbow that is affected by the disease, then the one on the other side will be as well. So again, repeating, that is symmetrical and it affects many joints. So we have clinical manifestations and we should follow rules. I'm calling them rules. What are these rules? Well, we have the acute phase We have the post-acute phase and its symptoms. We have a chronic phase and its own symptoms. In each phase, you will see different symptoms, different manifestations. So chikungunya in its acute phase is different from a clinical standpoint than chikungunya in a post-acute phase. And it will also be different than a chronic phase symptoms. So if I know that a viremia is being caused, but then the virus disappears, but the immune system is activated in joints, then very clearly I can understand that when I see somebody in the acute phase in the first week, for example, this person has chikungunya, I can expect to say fever and an acute disease. In the post-acute phase, I can expect to see the joints affected. And in a chronic phase, I can expect to see some joints affected, but that could also be producing sequelae because we saw that this disease could destroy the tissue, the cartilage, and this could be similar to rheumatic arthritis. So, following these rules, we can see that there are severe cases. These severe cases are characterized by the possibility of leading to death. This is not a simple viral disease that will work out in the end. I am dealing with a disease here that could, at some point, because of another comorbidity or because of the serious symptoms that it might produce itself, lead to death. And we can see in Paraguay cases that are associated to shock, and we are still studying this in details, but it's possibly cardiac shock. So we see here a disease that on its own, even without comorbidity, could kill. And this is similar to dengue in this sense, because it could also produce shock and kill patients. And in the acute phase, we also have the neonatal manifestations, which can be completely different than the manifestation in adults. So here in the acute phase, let's take a look at the common symptoms. These are symptoms that I expect, what I see a lot in my practice, what I see every day, and that's fever. We talked about this. Rash, you saw this in the 50s and in the 1960s, the edema on the face and extremities because of the inflammatory component. There could be some bleeding too in children, but even in adults. And this rash could also generate itchiness. We know that the patient can have muscle aches because of inflammation and necrosis. We also know about the activation of the immune system and the joint pain, and there could be periorbital pain. And obviously, with high fever, there could be headache. And now, different than dengue, you could see lymphadenopathy. This could be generalized, cervical, retroauricular, different types, and this helps us differentiate a chikungunya case from a dengue case or any other disease that involves fever. In the acute phase, I could also see diarrhea, vomiting, and abdominal pain, and mental confusion as well. And we could also see optical neuritis, and this would be very severe. And this is different than dengue. Chikungunya is more similar to Zika in this case. It could create ulceration in the gums or in the mouth. This also helps diagnosis. So if you're looking at a case and you think it's dengue and then suddenly you see oral ulceration, it is not dengue, it's probably chikungunya. And the conjunctivitis as well could be involved. In the post-acute stage, you will see that there is no fever. And why? Because the viremia decreased. You have no viremia, so you have no fever. But you continue having a viral RNA in the joints. So you will see inflammatory arthralgia. And what does that mean? Arthritis and synovitis. So this is the membrane that is in the joint and that can get inflamed. So when it is inflamed, fluids could be retained there, and then this causes a joint edema, which is very frequent. And besides the joint, you have tissue around the joints, you have tendons that could become inflamed. In that case, it's tenosynovitis, and this could cause joint stiffness. Many times the patient will need help to get up, for example, in the morning. This joint stiffness is very significant in chikungunya, and it's more pronounced in the morning rather than in the afternoon. And an adult, a woman with chikungunya, will probably ask for help to get up in the morning. And another thing that gets our attention is this decompensation and degenerative or traumatic arthropathy. So those people who already have this problem will end up having the symptoms of the disease in the joint where they already have problems. So repeating, you have the symmetric situation affecting multiple joints, but it could be asymmetric if the patient already has a problem in one of the joints. So when the patient um, gets the disease, the joint that was already affected by something else will be more affected by chikungunya. And in the chronic stage, what do we see? We see articular arthritis, and this begins a process that might be degenerative. It is chronic condition, and it could continue. If you have neuropathic pain or chronic pain, this could activate receptors and then generate neuropathic pain. How do I know if this chronic patient has neuropathic pain? Well, you notice paresthesia, um, and this is not produced by the virus directly, but it is produced indirectly by how the nerves are affected, and this generates neuropathic pain. And of course, we treat this kind of pain in a different way in relation to how we treat um, other kinds of pain. And here we have the severe cases. Chikungunya is not a benign disease and everybody is going to recover from it. Sometimes it will become severe and it could also affect other parts of the body that are not the joints. So any kind of manifestation in the nervous system should be considered severe, and this could cause seizures, strokes, cerebralitis, facial palsy. The behavioral change could happen to some patients as well. And we have noticed in the cases in Paraguay a cardiovascular issue that produces shock, heart failure. This is difficult to establish in practice. Is it the heart? Is the shock related to the heart? It's difficult to determine sometimes, but when you see a child or an older person with chikungunya, you should examine the heart. This should be done carefully to avoid cardiac shock. And I should avoid not being surprised and not recognizing this. So we're still looking at severe cases here. Other organs could be affected by the disease. There could be renal failure, for example, or there could be renal failure when people already have comorbidity. So we could see some cases, 1.2 creatinine case that a person already has could already be renal failure, and sometimes it is not recognized as such. We could see bullous dermatosis, pancreatitis. We need to understand that chikungunya is many times associated with fever and joint pain, but we could see a more systemic situation. Here we have a severe case. We see the signs on the skin. Unfortunately, that led to death. In that case, we can also see a maculopapular rash. We can see that on the hands. And we have other diseases like measles that don't affect the hand as much. And this helps us with the diagnosis. And syphilis is a different kind of rash. Here we can see a discoloration of the skin in a post-acute phase. And this is serious because it's also aesthetically um, something that people worry about. You have the situation here with the edema on the face, and you can take a look at this ear here. You can see that the rash isn't here, but there's swelling. So there's an inflammatory process in the tissue. As I mentioned, the virus is attracted to cartilage. And here you have a pseudochondritis. It's not exactly a chondritis, but the patient could develop a pseudochondritis. Here you see rash again, you see the hands and the feet. Sometimes the rash is intense, sometimes it's itchy. This is how we also research. You try to press and then you take a look and see what happens to the color. You need good light for this. And there's also conjunctivitis that could happen in some Zika cases, but it could also be associated to Kawasaki disease. So we need a differential diagnosis in this case, especially among children. Here you see this image that is very clear with adenopathy. Here you see a facial edema. This is something that really bothers the patient. And we should remember that we have the joints being affected, but also the tissues around the joints. So we kind of expect to see edemas. It's not just joint pain. You will see edemas here around the joint area, and this could also help with the diagnosis. Here we can see oral ulcers, vaginal ulcers as well. Here you can see a pseudochondritis. This really bothers the patient, and sometimes patients will go to the doctor because of this symptom. And here you see in the second picture after he recovered from this condition, and here you can see the joints and the area around the joints being affected. Here we have some interesting images, and it will be available on YouTube when we're done. So it's good to take a look at the images so you understand the process. And in the chronic phase, it could also cause stiffness. So you can see how the fingers are bent, and this can be very uncomfortable for the patient that has chikungunya. Let's take a look at children. The diagnosis in this group is a little bit more difficult, especially because the children have fever frequently. And so the epidemiological connection should be considered for all patients when we are dealing with infectious diseases. So let's take a look at that. But basically, what you see in children is irritability. And children, especially the younger ones, could frequently have blisters on their skin or could have a bullous erythema. And the newborns can have severe cases, which is characterized by fever. They refuse to eat and they have a lot of pain. The pain generates irritability and it can be unbearable for the children. You can see how this child is in pain. You can see it in the pictures. It is very painful for the children, and they have rashes as well. They have exanthem, irritability, and the newborns here can have very serious conditions. It is similar to a sepsis case, and sometimes when they are admitted, this is what is believed. You can see how irritable this child is. This is another patient. They look like a little doll, sometimes a rubber doll. This is also an interesting manifestation that we see. We also have shocks, blisters, the peeling in blisters. This reminds us of other diseases too, like Staphylococcus. And so the expectation is not to see just joint damage. This can be very serious, such as this one that is similar to something produced by a bacteria. Cyanosis could happen. Here we see a case. And we see hemodynamic effects. And here we see malnutrition as a pretty dramatic case for this child. So here we have fever, joint pain, but there could be many other symptoms associated to chikungunya. The main differential diagnosis is related to dengue because dengue also produces joint pain, but rarely produces edema in the joints. But it could lead to shock. So we do need to consider that it could be dengue. And then after 7 days, we could start considering chikungunya. We have, of course, Zika because of some of the similar symptoms. We have the Ross River virus that produces a very similar manifestation to chikungunya. Every pediatrician sees parvoviruses, which is joint pain and fever, but it's a benign case. And rubella is usually controlled in most of the Latin American countries and in the Caribbean as well. The enterovirus and adenovirus viruses could produce similar manifestations, but they do not generate outbreaks such as we see in chikungunya. So these viruses do not create situations where you have 100,000 cases or many cases like this because there's some immunity. In South America, we have a Mayaro disease, which is very similar. The lab needs to be involved so that we can have the differential diagnosis. Arapuxia in Brazil also produces a very similar disease, but after 30 days, usually we have this being cleared, and hepatitis C could also be similar in symptoms. And the diagnosis that goes through the lab also needs our attention. The viral culture is something that almost nobody does anymore for chikungunya except for reference centers. But the great tool for diagnosis, at least in the acute phase, is the detection of the viral RNA.
There is an availability of a tri-factor tests that can detect also dengue and chikungunya and other diseases. It's highly sensitive, and the advantages is that it's very specific. Once you find viral RNA for chikungunya, so you know that it's chikungunya. So at what point do you detect the RNA? Ideally, this should take place during the viremia. And when there's a high fever, the person reaches out to healthcare, and we have to seize the opportunity to draw blood, send the blood sample to a lab, and also request the research to see if the chikungunya RNA virus is present. So this is the most sensitive and most specific way to detect an acute case of chikungunya. When you request IgM antibodies, it's very useful also if there are IgM that can be detected. It could be a chikungunya case, but it's not a confirmation because IgM, as we have said before, can stay around after months once the person has healed. So the person might have had chikungunya 6 months away. There could be fever, leptospirosis. So IgM for chikungunya could show a reactive result when there is a node infection and not an actual present infection. So IgM is cast aside because it's not a test to confirm the case. this could be a probable case. A fourfold rise in IgG titer requires blood drawing, and it hasn't been used in Latin America and the Caribbean for healthcare. So if I see a suspected case, the ideal situation is to do a viral RNA test. So to establish what a case is, it's a epidemiological tool that we can use. So how do we define that? We can have a suspected case, a probable case, and a confirmed case. When do I suspect there's chikungunya? In the case of adults and older children. This happens whenever this person has been in the last couple of weeks to an area where there is chikungunya transmission, or they live in this area. This area is an area that has the Aedes mosquito. This is a fever disease. So it's very unlikely that we're going to have chikungunya without fever. So there's fever together with arthralgia and a joint pain. So this could happen also with pain and joint symptoms. We have to remember that we always have a differential diagnosis, and I do not explain this joint pain because of other situations. So if there is rheumatoid arthritis, that could be another explanation. There could be a parvovirus also, so that's not chikungunya. Therefore, I should always try to find some other issues that go beyond the joint and can change the classification. So this is a suspected case. A probable case is whenever a suspected case when there is a positive IgM or an epidemiological nexus when you know there is more than one confirmed case, say, where the street where they live. So we understand that there's an epidemiological nexus. So ideally, we request the viral RNA so that we can confirm whenever as possible in order to confirm chikungunya. You can't confirm chikungunya when you detect IgM for all the reasons we have covered before. And then I have to classify the situation. If there's fever, joint pain, a serious case is when there is a failure of at least one specific organ, like a kidney failure, shock, or an organic failure of the whole body. The person can be going into a coma, so there's a failure of the nervous system, or extra joint cases. For instance, you can have a pericarditis without systemic issues, or blisters. All of these are dermatological skin cases that goes beyond the joint. So if the person has a rash, it could be beyond joints, and this is part of the clinical symptoms of the disease. We have talked a little bit about diagnosis. It should always happen through the RT-PCR, and the serological can take place also with the MAC ELISA. And in case there's death, ideally, you have to do the necropsis and do the immunohistochemia for these patients. In general, this is how we receive the reports. We don't have a non-detected results in the molecular tests, and then we can establish if the results have been detected or not. When we have serology, we have the reagent, and sometimes we have two different types of tests. And the PAHO has reviewed everything and have found evidences, scientific evidences, that were used as a reference by arbovirus experts. And there are some findings that are highly certain to determine if it's a arbovirus or not in terms of disease. So you have rash, conjunctivitis, myalgia, bone pain. All of these are signs from a clinical point of view that are related to arboviruses and are different from other infectious fever disease. So also there's a drop in platelets. There's also leukopenia for dengue. And this helps us differentiate dengue and other diseases. One point that is moderate but can differentiate arboviruses, non-arboviruses, is the buildup of fluids and the inflammation of joints and chills. Chills indicate that there could be a high level of bacteria or a high level of viruses, so that we can say that in Zika, we don't have the chills because there's a low viremia. And the lack of taste or loss of taste, you see this in the cases of COVID and dengue. And and also we can tell that there is a difference between this and other arboviruses. And once we can establish all of that, we should use the publications from the 1950s. We can have a compromise of the joints, a very significant amount of pain that makes the person unable to do anything. There's inflammation, fever, and high level of pain, so that most likely is chikungunya instead of other diseases that are caused by arboviruses. If the individual is suspected of having chikungunya, you have to understand whether it's acute phase, post-acute, or chronic, if there is any compromise to the joints, if it's serious, or other comorbidities, and also whether they're very young or very old, or in case of pregnant women. And we also have to take into consideration the hydration of the patients. If you know that the patient is hydrated, is when the person is able to urinate and there's no, they're not thirsty and the urine is very clear. Treatment has to be very quick. The person has to rest and has to be very well hydrated. Hydration means to support the loss of fluid, and any patient that has chikungunya has to be seen by an adequate healthcare professional, any kind of healthcare professional, and this patient has to be checked for hydration. In general, the people who have chikungunya due to the high fever needs to be rehydrated, and this has to be carried out under supervision of healthcare professionals. We can't just request the person to drink water. The person has to be told how much they have to drink, and in primary healthcare, there should be water, and they have to come out of the healthcare unit after having drunk the water. We need to come up with pain management. And pain management is making use of paracetamol or dipyrone. If not, there's no response, we can use codeine and tramadol. So all the NSAIDs are not used here. And during the acute phase, I can go through the first week with a diagnosis that it's not dengue, and after that, I can use a NSAID. There's no indication to use corticosteroid during the first week, and we always have to carry out a functional treatment. We have to immobilize the joint and use some icing, and there has to be some light movement around the joint so that the person isn't in so much pain. And of course, if there is a pillow radiocooley low neurosis, you have to take care of that. And if there's a general failure of the body, you have to take care of that. But during the acute phase, you have to make use of corticosteroids. So rest and fluids, taking care of pain with over-the-counter medication like acetaminophen or paracetamol, dipyrone, which is highly used in Latin America. No use of aspirin because there could be dengue. And you must not use non-steroidal anti-inflammatory drugs until dengue can be ruled out. And if the person has chikungunya, we have to prevent mosquito bites, and each country has their own recommendations and guidelines for that. And what I have to do is avoid the mosquito bites because this person will infect others. And for treatment, we have the dosage of paracetamol that we have to use. We have to respect the 4 grams of paracetamol per day, dipyrone 1 gram per day. And like that, the person is taking the medication so that they're free of pain. If there's no response to paracetamol or dipyrone, and I know it's not dengue, at this point, I can use a different type of anti-inflammatory drug, naproxen, ibuprofen. And if you haven't ruled out dengue, you can't use anti-inflammatory. And these anti-inflammatories, they can be used only over the course of 2 weeks. Some NSAIDs, they can affect the gastrointestinal system and also lead to cardiovascular disease. I have to assess if this medication can be used with clinical assessment. If there's no response, then I will use an opioid so that we can sedate the patient. And of course, glucocorticoids or immunosuppressive drugs cannot be used during acute infection. I have to remind you that chikungunya can lead to severe diseases, and you have many times to hospitalize patients, especially young children, immunocompromised patients, patients with comorbidity, elderly adults, and we have to assess and the patient, and of course, we cannot use chloroquine in these situations. I have to assess if there is synovitis or joint swelling. In the post-acute, I can use prednisone with a very low dosage and decrease it and taper it over the course of 10 days. So it's not an immunosuppressive dose. I can do this over a course of 5 days, tapering it over the course of 10 days. So that's the rule. I will not use the glucocorticoid for intra-articular uses. If this person has a chronic disease that will lead through more than 3 months of symptom, I have to send this person to rheumatology services. During the chronic situations, we treat it like chronic inflammatory arthritis using the MTX, which has to use a monitoring of any kind of liver symptoms. And I can use a very low dosage like 7.5, 10, or 12 or 15 milligrams, and just verifying if this person has a chronic disease like hepatitis that could be made worse. So the tumor necrosis factor inhibitors have been effective, have been resistant. Neuropathic pains have shown that they will not respond to anti-inflammatory, and we need to use other drugs. Here is a sequence of how we carry out the treatment. First, we start with painkillers. We see if there is any neuropathic compromise, and then if there's no response, we use the opioids. Same thing, we have already covered all this area, and we must remember that I can use icing and physiotherapy with very light exercise. The prognosis is good. Almost 100% of the patients recover, but some of the people who have a serious disease during the acute phase, or some that have an underlying situation, can have other problems. We have to avoid mosquito bites. Up to now, there's no vaccine. And when we talk about population, we have to control the mosquito population, which is very important. We always request that this person will help with any control. So this is the final conclusion. Chikungunya is still regarded as a priority pathogen that requires better healthcare with research, and we need the international organizations to take care of that, as we have this meeting today, so that research can find better response to chikungunya, that is a mosquito-borne disease. And right now, all that we can do is to try to prevent and avoid the disease. So I will stop here, and I'm open to questions and discussions.
Muchas gracias, Dr. Kleber, por su presentación. Excelente presentación.
Dr. Kleber, thank you very much for that excellent presentation. Actually, we have many questions that have been posted. Let me try and see if I can sort them into several groups to make this a more interactive. So the first question, what are the symptoms? What are the symptoms of an atypical case of chikungunya? And have we seen that atypical where we have results where we have comorbidities? And the second question has to do with G1-2A mutations, and if this mutation is responsible for some of the recent deaths that have been recorded.
I'm going to start with the second question. The strain that you mentioned is going around, and it's most likely responsible for the high death rate that we have been observing now in South America. Regardless, the spread of the disease is all over Paraguay. So when they affect the elderly or young children, this can lead to a very serious disease. It doesn't seem to be a mutation itself that is responsible for the serious case, but we're still carrying out studies. What is an atypical case? This terminology shouldn't be so widely used. What would be an atypical case? It's a chikungunya case with fever and joint pain that has a pericarditis. So it is a very infrequent case. And when there's an epidemic, you will see many people with chikungunya, and of course, you're going to see an atypical situation. But ideally, it should be classified as chikungunya with manifestations and issues beyond the joints, and that is serious. So we call it atypical because it's not very relevant for dengue, for Zika. It's a very old terminology used for arboviruses, and this is only used for chikungunya with any symptom beyond pain and fever.
Thank you, Dr. Kleber. I just wanted to get back to the mutation question. We've seen a sequencing of the virus recently during the outbreak in Paraguay. Has that happened? And although we've seen that the variant is the mutation is not present in this strain that is circulating in Paraguay. Let's move on to the next question, Dr. Kleber. Is it possible to have two arboviruses at the same time? The second question, what's the level of mortality when this involves the central nervous system? And people who survive, what are some of the after effects?
In general, once you do the molecular assays, you can find two viruses in the blood. And we call this co-detection. We don't call it co-infection, because co-infection, a disease will change one another with HIV, tuberculosis. So what we see, it's the co-finding, and the expectation is that the clinical symptoms are of chikungunya, and there's no record of this generating any kind of clinical manifestation that is relevant and has to be taken into consideration. But in medical care, in healthcare, we can treat this person with dengue, because this dengue can lead to shock and kill the patient. And as far as the nervous system compromise, we can have the Guillain-Barré syndrome. And one thing that is very clear and that can take place is the compromise of vertical transmission from mother to child. In 50% of the cases, there can be a compromise of the nervous system with encephalitis, and this compromise with encephalitis or prenatal infection can lead to a death rate of up to 40%. But the sequelae, I don't know. I don't have a general information, but we don't expect these people to have problems or like mobility problems. And usually the elderly who had a chikungunya, they have a cognitive loss. But this was a study that was carried out in a small number of people, so we don't know how many and how much can take place in terms of cognitive loss. But we knew that in the 50s there was a compromise of any kind of rural activity in Africa.
Thank you, Dr. Kleber. The next questions include the following. We have, well, Dr. Kleber, immunity as a result of chikungunya, is that long-term? It depends on the variant? And the other question is, what are the perspectives from the public health perspective in light of the spread of chikungunya, where we may have permanent after effects with people who have been affected by the disease?
Chikungunya leads to long-lasting immunity. It means that person will never ever have chikungunya again, more or less like measles and other types of diseases, like like different poxes. So it would be very unlikely that someone will have chikungunya more than once. And you have a very high number of immunodepressed people, but that usually doesn't happen. The healthcare perspectives are not very good because we don't have the engagement of the population to control the mosquito. The public in the government management isn't good, so it's very difficult to control a disease when there's a vector, there's no vaccine, and this is almost impossible to take place when there's no involvement from the population and from the government. And the global warming leads to a spread of the Aedes mosquito, so we think that over the next 25 and 30 years, we'll be still talking about that.
I'm going to ask you three questions that are very brief. The first one is, can chikungunya result in cough? And are there certain warning signs with chikungunya as we have with dengue? And third, arthralgia. The chikungunya infections would require a differential diagnostic as opposed to arthritis, rheumatoid arthritis.
Chikungunya does not lead to any coughing like any kind of breathing issue, but there could be a dyspnea like any kind of lung disease or a heart disease. So you can see that a dyspnea due to asthma, due to a lung disease that is a chronic obstructive disease, and not by a direct relation with the lungs like COVID or the flu. As far as the management and treatment of chikungunya, there's no red flags. What would be a red flag? A red flag would be like with dengue. Dengue has very clear red flags, like the increase of hematocytes that have to show that it's a more serious disease, like a very intense abdominal pain. So this person could have another find themselves in another situation like the shock. With chikungunya, we can have the chikungunya and a serious manifestation of chikungunya, but we don't have a laboratory or clinical marker like what we have for dengue. So a red flag does not apply for chikungunya. At least this is the opinion that we have. And I'm sorry, I have forgotten about the third question.
The third question has to do with arthralgias in chikungunya. Would that require differential diagnostics with rheumatoid arthritis?
Yes, but you have to go through the chronic disease. There are three phases: the acute, post-acute, and chronic phase. During the chronic phase, all the differential diagnosis has to happen with any kind of joint chronic disease like rheumatoid arthritis.
I'm going to ask two questions. According to the actual history of the disease, what would be the appropriate time, most appropriate time, according to your experience, to detect with laboratory testing? And what has been your experience with immunochromatographic testing?
Ideally is to detect RNA during viremia. Viremia is higher during the first 5 days. 1, 2, 3, 4, and 5 days. And it can carry over into the 7th day. It doesn't matter if your healthcare department allow the molecular test to be carried out on the 7th day. So we use blood preferably, so you don't collect any urine, but if there's any acute manifestation, yes, you can have for the RT-CPF for the other tests. Sometimes for very young children, when you have any kind of blister, you can use the material found in the blister, and this can be sent to labs, and this can lead to a positive test. But these are very specific cases, and it's not the general situation. The chromatographic test will not show the antigen as for dengue. The IgG can be positive late in the infection, or during the first days of the disease can be negative, and it can help with diagnosis without confirming anything. So ideally, we have to get organized and carry out the adequate tests for the PCR tests. But we have to do the treatment with clinical and history and clinical examination, which will help you manage the chikungunya cases, casting aside any kind of issues with dengue.
Thank you, Dr. Kleber. The next question has to do with chikungunya and pregnant women. And one of the questions is chikungunya, is it transmitted during pregnancy? And at one point, is the disease transmitted? And in case that it is, what are the potential harm to newborns? Or does the disease, can it lead to abortion during the first period of gestation?
There are reports of pregnancies being affected by chikungunya, but at least until now, this is not clinically and epidemiologically significant. These would be exceptional cases. What is very significant in pregnancy is that a pregnant woman could have viremia in the intrapartum period, 2 days before delivery, 2 days after, because that's when the virus can be transmitted to the newborn, and the newborn could have a severe case. There are no sequelae as in Zika, but there is a viral situation, and it's similar to a bacterial sepsis, and this could lead to death for a newborn. So any newborn that is born from a mother that has chikungunya has to stay in the hospital for 7 days, because during this period, there's a 50% chance that the newborn will develop a severe case. And we don't want this newborn leaving the hospital and then having to come back with a severe case.
One more question about chikungunya and pregnancy, and the question is whether chikungunya affected women has to be hospitalized just as with dengue?
Dengue. There is no such recommendation because the pregnant person will have cases that are similar to other cases. So we don't expect to see a more severe case in a pregnant woman. But of course, we need to evaluate this very well because pregnancy is always considered dengue, Zika, chikungunya. Um, we always, when we look at these cases, we always evaluate pregnancy as comorbidity, and we are very careful about it.
Thank you, Dr. Kleber. I have a question about dipyrone. The question is, dipyrone would not induce a larger thrombocytopenia with larger risk of bleeding?
The bleeding cases in chikungunya are not the main symptoms. In dengue, this happens when there is a shock, but dipyrone does have an anti-inflammatory component, a small one, and we consider this if it could be used for different patients, but our experience in Latin America is a long one in this area, and we do not believe that dipyrone will make these diseases more severe. So we see this in handbooks, and I believe it can be used.
I will have a comment because we get very frequently this question about dipyrone and dengue case. I would like to say that the recent guidelines published by PAHO for the management of dengue, chikungunya, and Zika were published in 2021, and the use of dipyrone was one of these questions. And the evidence found in this systematic revision, there was no evidence not to recommend the use of dipyrone. So currently, dipyrone can be used even in dengue cases to control pain and fever, whether it's the oral administration. The next question, what factors do you have for the expansion of chikungunya in the southern cone beyond what you mentioned in the presentation? And also in Uruguay this year, we have had our first chikungunya cases in history imported, but also indigenous.
This is what we expect. We think the number of cases will rise. So we need to plan. As clinicians, we need to train people so that they can manage these cases, so that nobody is using corticoids or anti-inflammatory medication in the first week of the disease. So we have actions to control the disease, but I think that the PAHO team would be able to answer this better from a long-term work point of view. But as a doctor, I need to train people because it might look like it's easy to manage a chikungunya case, but we do see in practice a lot of mismanagement, and this could bring problems to the population.
Two more questions. What lab studies are basic to detect complications for the early detection of complications in chikungunya? And the second question, how many days of evolution pancreatic and heart complications are frequent? When do they occur?
Well, in the past, chikungunya was split in phases, phase with fever, and in this fever age, complications could go up. So we have high viremia in this phase, and this means that the innate immune system and the adaptive immune system are greatly activated, and they have a dialogue among themselves. And this creates a lot of cytosine that are pro-inflammatory. And this generates the complications, the organic complications, besides the virus, the presence of the virus. So heart failure, pancreatitis, kidney failure, all of this could happen in the first 10 days. of the disease. We don't expect it to happen later. What could happen after 2 weeks in the post-acute phase would be a Guillain-Barré. Also, skin complications could happen later, and the joint complications show up in the chronic phase. But the severity there in this case is in the first 7 to 10 days. The lab doesn't work specifically with chikungunya. So they could see lymphopenia, and they could also produce a protein C reactive test. But what we need to see is clinical examination, because that's what is very useful for the diagnosis. And this happens in the case of other diseases that have mosquitoes involved too, because you need to do that to manage your patient. You shouldn't be waiting for the lab or waiting for any confirmation test. But of course, if you have an 85-year-old patient that has chikungunya, and this person already has kidney failure as a comorbidity and is already going through treatment, of course, you have to assess the kidney functions. In Rio Grande do Norte, when we have uh, our cases here, we take a look at the diabetic places. I have to examine the markers for those diseases because I need to manage this. So for chikungunya, we manage the fever and the pain and the comorbidity. So we need to control uh, the oxygen, for example, if the patient has asthma, and we need to manage the comorbidity. So it's not simple. It's not just give painkiller or corticosteroids. You need to manage the patient as a whole. And this is the main message here today.
A few more questions. This next one has to be with chronic manifestations of the disease. And there's a case of a patient that a month ago had chikungunya and now has swollen hands and feet that are very painful. What would you do in these cases where there is a reactivation of the disease or when these manifestations have lasted more than a month?
In the chronic phase, because remembering here that we have the acute, post-acute, and chronic phases. So in the chronic phase, after 90 days of disease, the joint complication is something persistent and something reiterated. So it's persistent because sometimes there's no immediate and fast reaction after receiving medication. And it is reiterated because patients get better and then worse again. So this is why when we are treating a patient with methotrexate, we need to do this for several weeks. You're not just going to treat the patient for 2-3 weeks. They are not going to improve. But after 2 weeks in the post-acute phase, we don't use methotrexate. We use a non-hormonal medication. We have to verify gastrointestinal issues, and there are medications that affect heart and stomach, so we have to be careful with that. But with a month of the disease in the post-acute phase, we can use corticoids. We can use prednisolone, 10 to 20 milligrams per day. It's a low dosage for 5 days, and then we taper it out. The patient improves, and then after 2-3 weeks, they will be sick again, and we repeat the treatment. So in this post-acute phase, we have to use low dosage of corticoids for short periods, and then you taper it out and follow the patient, and sometimes you go back. And you should also try to observe neuropathic pain, because in that case, you would have to use different types of medication.
The last 4 questions. The first one has to do with the shock described in chikungunya. Is it mostly septic, bulimic, cardiogenic?
O choque se caracteriza pela má
The shock is characterized by low blood pressure and how the circulation is affected too. The mechanism could be septic, and it's distributive in that case, and cardiogenic or hypovolemic, etc. What we have seen this year in the cases that evolved into a shock in Paraguay, most of them, based on the information I have, is of a cardiogenic shock. There is cardiac complications that generate the shock. This is what we are seeing. We do need to still finish this assessment to understand it better. But what does this mean? It means that the shock management has to be careful considering fluids, because if you add too much fluids, you could create pulmonary edema, and that would lead to death. So we are not just considering the septic or distributive shock. Apparently, there's a
The
cardiogenic
second
component
question
to
has
it.
to do with the clinical lab diagnosis. How do I distinguish an chikungunya IgM from the one from chikungunya by clinic?
The distinction is always clinical, epidemiological. Can somebody with dengue having a fake IgM for chikungunya? Yes, we could see how this could happen. We could discuss this in another opportunity. Somebody could have chikungunya and have an IgM for dengue, and vice versa. But if we are seeing a patient that has no diagnosis, the patient is in the post-acute phase, I cannot use the RT-PCR anymore. So in a second dengue, I could have only IgG and negative IgM, and chikungunya would be positive. So somebody who has been sick for 60 days and didn't have the chance to go through an RT-PCR and is positive for chikungunya and negative IgM for the other one, then I could consider this. If it is negative for chikungunya, it's possibly not chikungunya, but it's a different disease.
Thank you, Dr. Kleber. The next question: in dengue and Zika patients, also corticosteroids are not recommended in the first few days.
Exactly. The corticosteroids are not used for serious viral diseases. We do that for COVID after the inflammatory phase, after 7 days. In pneumonia, we have this recommendation too, or at least it's discussed in the New England Journal. But that's a bacterial infection. For acute viral infections that could potentially be severe, we do not use corticoids. We need people to have an immune response to control the virus.
One of the questions addressed in the PAHO guidelines published in 2021 on dengue, chikungunya, and chikungunya, and evidence based on our systematic review indicates that the use of corticosteroids offers no benefit for the patient for the management of this disease. The next question, the last one, doctor, if there are congenital malformations linked to chikungunya.
No, we have not detected this. It's not like Zika. There is no possibility so far. We don't know what's going to happen in the future, though.
Well, we'd like to thank Dr. Kleber. Thank you for your time and having shared with us this very important briefing discussing the epidemiological situation. We know it's been very complex in many countries in the region. We want to thank all of our colleagues who have been connected in many of the countries in the North America, Central America, Caribbean, and South America, because please be warned that there may be an increase in potential cases of chikungunya, as we're seeing in the southern regions of Latin America. So we want to thank you all. We've had 445 participants with us. We know there are many people from throughout the world that have been listening to this very interesting briefing provided by Dr. Kleber Luz. We want to thank you very much and have a great afternoon. Thank you. Goodbye.